Good evening, everyone. I warmly welcome you all to today's webinar on early pregnancy complications. It is my privilege to introduce our esteemed speaker, Dr. Arshia Sayed, an accomplished obstetrician and gynecologist with MS in Obstetrics and Gynecology and extensive experience in tertiary care teaching hospitals. She currently serves as an assistant professor and has expertise in high-risk obstetrics, obstetric emergencies, gynecological surgeries. Uh, she also does teaching, mentoring, and research as well. So we are delighted to have her with us today and warmly invite her to take over the session. Over to you, madam.
Hi, good evening, everyone.
You're audible, madam. You can continue.
Yeah. Is the screen visible?
Yes, madam, it is. Yes, doctor, it is visible.
Shall we start the session or should we wait?
No, it's already session was supposed to start at 7 o'clock. We
Yeah,
gave them
correct.
buffer time as well. So I think
Okay, so we'll begin, right?
yeah, we can begin.
Okay. Hi, everyone. So today we'll be having a discussion on early pregnancy complications. Today's webinar will mostly be a case-based approach, okay? So I'll be initially giving you some case scenarios, and based on that, I would like to first get your input on it, and then we'll proceed on the discussion part of it. Okay. So the session mainly covers the first trimester complications, approach to bleeding, pain, and vomiting in early pregnancy, how to differentiate various types of miscarriages or abortions, ectopic pregnancy, and molar pregnancy, how to interpret the beta HCG report and ultrasound finding in early pregnancy, and how to apply this basic principle of management in case-based scenarios. Okay. So first, what I would like you all to understand is pregnancy, what happens is there are some symptoms which may seem abnormal, okay, in a non-pregnant state, but in pregnancy, it is normal to have those symptoms. And these kind of normal symptoms, I would like to address them as, so they are amenorrhea. Like the first thing the patient will have the history of amenorrhea. Okay, amenorrhea is like she's supposed to get her cycles, like if it's a 30-day cycle, 28-day cycle, when she's due and she's missed that period. Okay, so that is counted as a period of amenorrhea. Okay, next, having nausea, vomiting, these are, and giddiness, these are all, signs in which the woman will know that she's pregnant. Okay, so these are symptoms provided by nature so that the woman understands that she's probably having the chance of being pregnant. Okay, so these are so-called the normal symptoms. So when do you address, symptoms to be abnormal in pregnancy? So having any sort of abdominal pain, vaginal bleeding, or excessive vomiting, these are all abnormal symptoms to be seen in the first trimester. So such symptoms, if the patient presents with, definitely it has to be addressed to. Another thing, what we look for is when somebody comes to you with a history of amenorrhea, the first thing that you would like to look for is, first thing that you have to rule out, okay, in any scenario is a pregnancy test. And that pregnancy test can be done anywhere at any point, but by using the UPT kit, the urine pregnancy kit, Okay, and you're using the patient's urine sample. A simple test of UPT can be done to check for positivity of pregnancy. Okay, so now what is the beta HCG value in your blood, which will be which is needed for the urine pregnancy to come positive? That is 20 to 25 milli international units per ml of beta HCG in the blood for the urine pregnancy test to come positive. Okay, so you must have heard that patients sometimes they may tell that the UPT test was done but it was faintly positive. Okay, or sometimes um yeah, so these are the conditions where the beta HCG might be slightly on the lower side. Okay, so that's why it may come as faintly positive, but for it to definitely come positive, it has to be more than 25 milli international units per ml. Now, what is this beta HCG doubling time? So this beta HCG hormone, which is a hormone of pregnancy, okay, this hormone, what happens is if it is a normal intrauterine pregnancy, this beta HCG doubles, okay, doubles by 66%, okay. So that is called as a doubling time, and this takes place in 48 hours. So what happens is in most of these abnormal pregnancies that we think of, okay, for example, abortions or ectopics, okay, so or if you're suspecting that it might be a failing pregnancy, so in such cases what we do is we do a baseline beta HCG. Suppose you've done a baseline beta HCG today at like what, 7 p.m. So after 48 hours, okay, you will repeat the beta HCG and you'll see. So if the beta HCG is doubling, okay, it's become double the than what that value was. Okay, so that means it is a normal intrauterine pregnancy. But in case it's not doubling, okay, or in case it is falling, then you can think of any abnormal pregnancies like a pregnancy of unknown or a location or ectopic, or a case of a failing pregnancy or an abortion. So that was about beta HCG. Next, another modality that we use. So these are the most commonly used tool in first trimester. Okay, that is your beta HCG value or the beta HCG, either detected by urine pregnancy test or serum beta HCG. Another one is the transvaginal ultrasound. Okay, transvaginal ultrasound is more preferred than transabdominal ultrasound. It is because the visibility, because see, at this point, the uterus is a pelvic organ. Okay, so the visibility per abdominally is less. That's why a per vaginal visibility is much better. Okay, so that is why a transvaginal ultrasound is preferred in first trimester. So the most earliest sign that can be seen in case the patient is pregnant, that is a thickened endometrium. Okay, normally the endometrium may go up to 12, 13. Okay, so what happens? The earliest sign will be the endometrium will become thickened. You'll see an endometrium of 16 or 18 mm. Okay, so that is the most earliest sign of pregnancy. Okay, next, so this appears at 4 weeks. The next to appear in on ultrasound will be the gestational sac. Okay, the gestational sac will appear at around 4.5 to 5 weeks. The next to appear is yolk sac, which is around 5 to 5.5 weeks. Following that is when you see the fetal pole. Okay, so that is around 6 weeks. So in transvaginal ultrasound, at 6 weeks, you should be able to look for the fetal pole. And then the cardiac activity starts developing by 6 to 7 weeks. So that is why the first trimester ultrasound, if in case there is the patient is not having any of these abnormal symptoms that we spoke about, if any of that's in such situation, we usually recommend a dating scan or an early pregnancy scan by between 7 to 9 weeks, because that's when all these features would have appeared, isn't it? So that's when you will be able to clearly see. Otherwise, if you've done a scan way too early, okay, in somebody who's having a normal pregnancy, so it'll just put the patient in that worry. Okay, the baby has not yet start developing, the heartbeat has not start developing. Again, you'll have to subject the patient to a repeat ultrasound. Okay, so but in case you're suspecting that no, this could be a case of ectopic pregnancy, or missed abortions. Okay, somebody who's having a recurrent pregnancy loss. Okay, in such situations, maybe doing an earlier scan would be of help. Next is, what is this beta HCG discriminatory zone? Okay, so for it is the beta HCG level at which the ultrasound will pick up something. So for you to have these changes in ultrasound, the beta HCG level should be somewhere between 800 to 1500 international unit per per ml. Okay, so that is called as the discriminatory zone. So that is when all these features will be seen on ultrasound. Because anything below this level, the ultrasound will remain inconclusive. And what is the significance of having a yolk sac? That means a yolk sac is something which if you see on ultrasound, it will confirm that it is a true intrauterine pregnancy. So that means this will not be seen in case of an ectopic pregnancy. Okay. So as we discussed, the first thing, what happens is inside the uterine cavity, you will find the endometrium to be thickened first. Okay. So first thing is the thickened endometrium as early as 4 weeks. Then the next to appear is the gestational sac. The sac appears next. Okay. After that, the yolk sac will appear. Okay. Next to appear would be the fetal pole. You will be able to record the crown rump length of the fetus. Okay, that is how you'll be able to determine as to the pregnancy is corresponding to how many weeks. Before the fetal pole develops, if only the gestational sac is seen, then you will take into consideration the mean sac diameter in order to assess as to what is the pregnancy, the period of gestation it is corresponding to. Okay. And then the next, if you if you turn on Doppler mode on your ultrasound, that's when you'll be able to pick up the fetal, you'll be able to hear the fetal cardiac activity. At the same time, the flicker of the cardia will also be picked up on the ultrasound. So these are the findings of the first trimester ultrasound. Is this clear? Can I move to the next slide? So in conditions where, the patient is probably not, able to recollect her last menstrual period, or conditions where, she's had a pregnancy, she's conceived in a case of lactational amenorrhea. Okay, in conditions like that where she's not sure about her last menstrual period. Okay, so she will not be able to tell as to how many weeks she is. Okay, as to how many months of amenorrhea she's had. So in such situations, your first trimester ultrasound will be of importance, because it is also called as the dating dating scan, because through this you'll be able to very accurately date the pregnancy. That means if the patient doesn't know her periods, okay, when she's got her last periods, but when you do an ultrasound, okay, when you measure, if in case the fetus is not seen, okay, you just measure the gestational sac diameter. By that, you'll be able to estimate how many weeks of gestation it is. Okay, and this accuracy is as good as plus or minus 5 days of accuracy. Okay, but if the fetal pole is visible, you can measure something called as the crown rump length. Okay, this is the crown rump length of the fetus. Okay, and by that also you'll be able to estimate as to how much it corresponds to. Okay, so the first trimester, if it is the first trimester scan, if it is done as early as before 9 weeks, the accuracy is plus or minus 5 days. If it is done after 9 weeks, it is having an accuracy of plus or minus 7 days. So for ease of remembrance, just know that first trimester ultrasound has an accuracy of plus or minus 1 week. Second trimester, plus or minus 2 weeks. Third trimester accuracy of dating the pregnancy, it is plus or minus 3 weeks. Okay, am I clear? Shall we move to the next slide? Okay. So now that I hope the basics are clear. If that's clear, I need a yes from you all so that we can have the discussion on the cases. Okay. So the case one, the first case that I'll be discussing is of a 20-year-old. Okay, she comes to you with a 45 days of amenorrhea. Okay, and following this, followed by resumption of her menses. Okay, so she had a 45 days of amenorrhea, and she after that she got her cycles. Okay. At this point, she has done her urine pregnancy test, and it has come as faintly positive. Okay, so when she went and consulted, a serum beta HCG was done. The initial value was of 40, and then when it was repeated after 48 hours, it it fell to 28. Okay, and at this point, since pregnancy was positive, beta HCG was also something which was showing pregnancy. Okay, a transvaginal ultrasound was done. Okay, and this picked up no gestational sac and no features of pregnancy. So what do you think this case is? A little bit of interaction from the participants would really, motivate the speakers to have a good interactive discussion as well. You can type in the chat box. Okay. Fine. So here the discussion is on biochemical pregnancy. So what is this biochemical pregnancy? What happens is biochemical in the sense the chemical, that means the beta HCG, okay, that has turned positive, but the pregnancy actually does not continue. Okay, there was no gestational sac formed. The beta HCG, though it showed some degree of positivity, it started declining very fast. Okay, and to start off itself, the beta HCG was on the lower end. Okay, and then with that low level of beta HCG itself, what happened is the pregnancy, it became faintly positive. Okay, after that, the repeat beta HCG started drastically falling. Okay, and the patient, she started resuming her periods, and a scan also showed no evidence of pregnancy. So this sort of pregnancy is just a biochemical pregnancy. You can call it mainly something like a hit and run. Okay, it was about to get implanted, but it went off. Okay, so that sort of a pregnancy is a biochemical pregnancy. So a biochemical pregnancy is an early pregnancy loss diagnosed only by a positive beta HCG without evidence of pregnancy, evidence of ultrasound, pregnancy on ultrasound. Okay, so, in your clinical practice, you will come across such cases where, the patient will give you such a history that, no, doctor, it was positive, but uh, I don't know what happened. Without any reason, it just went off and nothing even was picked up on ultrasound. So that sort of a pregnancy is a biochemical pregnancy. Case 2 is of a 26-year-old who has regular menstrual cycles, and she's somebody who's trying to conceive. Okay. And she comes to you saying that she had spotting a few days after she got her periods. She had complaints of spotting PV. Okay, mid-cycle. And then because she was somebody who's trying to conceive, she did a urine pregnancy test initially. Okay. And that pregnancy test came negative. So what she did is she repeated the urine pregnancy test after a month, and this time it has come as positive. But now the patient is confused as because when you ask her when was her LMP, she feels like she had two cycles. Okay, the one when she got her proper periods, the second time when she had that spotting. So now she's going to get confused as to did she really have a missed period or not, because that mid-cycle spotting is what confuses her. So what is this sort of pregnancy, or is this even pregnancy? Because initially it was negative, then it comes positive. Is it some sort of an abnormal pregnancy? What do you think this is? Okay, so the answer to this is it was an implantation bleed. So the patient is continuing to be pregnant, but that spotting what she had mid-cycle was an implantation bleed. Okay, so what is this implantation bleed? It is the light spotting that occurs when the blastocyst is trying to implant into the endometrium. Okay, so the endometrium, the blastocyst has to invade through the endometrium, isn't it? So that is when a little amount of bleeding is seen. So that sort of a bleed where, it is, see, this bleed is very light, okay, with just spotting, unlike a period bleed where you have a heavier flow. Okay, then this color is either slightly pink or brownish compared to a period bleed, which is bright red or dark red. And this sort of spotting will be seen just for 1 or 2 days mid-cyclically. Okay, but a period flow will at least be for 4 to 7 days. And this implantation bleed, they may or may not have mild cramps, okay, very negligible, not causing any sort of distress to the patient, but a period cramp will be stronger. So this sort of bleed is called an implantation bleed. What you need to remember is the implantation bleed is not similar to abortion, okay? Here the pregnancy continues. Fine. So next we will be discussing about the various types of abortions. So what do you understand by the term abortion or miscarriage? Okay, so abortion is the termination or loss of pregnancy before the fetal viability. So what is this period of viability? The word viability means that the baby is able to survive outside the mother's body. Okay, so where else will it survive outside the mother's body? That is in the neonatal care. Okay, so once the baby delivers very prematurely, the rest of that care which was given intrauterine will be given in the ICU setup. So that is called as a period of viability. So in certain places we take as 20 weeks. Okay, if you have a very well established neonatal care unit, okay, or there are some places where they consider either as 24 or 28 weeks. And either it is the weeks of gestation which is taken into consideration, or it is a fetal weight of less than 500 grams which is taken into consideration. So any loss of pregnancy before this period of gestation or before this weight of the fetus, it is defined as abortion. So now there are various types of abortions. Okay, there is threatened abortion, inevitable abortion, incomplete, complete, missed abortion, septic abortion, and recurrent pregnancy loss. So one by one, let's discuss the various types of abortion based on a clinical scenario. Okay, so a patient comes, okay, she gives the first history, that is the she has a period of amenorrhea, followed by a slight bleeding PV. Okay, the term here is slight. The bleeding has been a very light bleeding, and she didn't have a severe abdominal pain or cramps. It was just a dull abdominal pain or a backache. Okay, and when you palpate her per abdomen, the size of the uterus, it corresponds to the period of amenorrhea. Okay, so it is not neither less or more. Okay, it is completely corresponding to the period of amenorrhea. When you do a per speculum examination, you see that there is bleed, but there's just a minimal amount of bleeding and it is bright red in color. Okay, and when you do a per vaginal examination to look for the status of the cervix, the external os is closed. Okay, and the uterus, it feels soft. That means there is no contraction. Okay, and the uterus size also corresponds to the period of gestation. So what sort of an abortion is this?
Participants are leaving the answers in the chat box.
Is it?
Yeah, from your slide one, from case one, they are sending you in
I
the
am
chat box.
thinking why. Okay, yeah,
No,
it
no,
is not showing any notification.
Yeah, no, who is it?
I am thinking, why is the audience not
No,
able
no,
to
no, no,
think?
no. They're
Okay, okay.
interacting for all your queries. They're
Oh, I
interacting.
am so sorry. It was not coming as a notification, so I missed it. Uh, yeah. Okay, I'm getting the answers now. Thank you so much. Okay, so yes, it is a case of a threatened abortion. So what do you understand by threatened abortion? It's as the word, most of the medical terms are very self-explanatory. Okay, just by understanding the term, you'll be able to guess what the condition is. So here, as the term suggests, that it was just a threat. Okay, that means there was a threat that it might get aborted, but it was just a threat, but the pregnancy continues. Okay, so that type of an abortion is called as a threatened abortion. At this point, you can, as a doctor, intervene and try to save the pregnancy. So it has not gone beyond the reach where, beyond that, where, a medical help will not be needed. Okay, so you can still do something to save the pregnancy, is what I'm trying to get at. Okay, so yes, the answer is threatened abortion. So it was just a threat. As you see, there has been a little amount of trickling or a slight amount of bleed, but the baby or the fetus is continuing to be there. The gestational sac is continuing to be there. Okay. So, and the uterus, the size of the uterus remains corresponding to the period of gestation. So nothing the viability of the pregnancy continues. Like the fetal heartbeat will also be there. Okay, the fetal pole will also be the gestational sac will also be there. It will not be shrunken. It will be, as it's supposed to be. Okay, so that means the pregnancy can be continued if you intervene and you provide the right care to the patient. Okay, so by definition, it is the process of abortion has started, but further progression can be averted and pregnancy can be continued. So it was just a threat, and when the patient comes with this threat to the doctor saves the pregnancy. So that's what is threatened abortion. In this scenario, what investigation that you'd like to do is, since she already knew that she was UPT positive, okay, so and the pregnancy was confirmed by transvaginal ultrasound. At this point, what you will see is beta HCG. Okay, beta HCG, as we discussed, if it's doubled, okay, in 48 hours, that means it is a good intrauterine pregnancy, and this is routinely done. Serum beta HCG is routinely done, but serum progesterone is not a test which is routinely done. Okay, but just for understanding, the progesterone level more than 20 nanogram per ml suggests that it's a viable pregnancy. Less than 5, it denotes it as a dying pregnancy or a failing pregnancy. Apart from this, you're going to do a routine antenatal blood and a urine investigation, because at this point you would want to know as to what has caused this sort of a threat. Okay, in case the patient is anemic or the patient is having an underlying infection. Okay, her total counts are high, or her urine is showing some pus cells. Okay, or if her thyroid levels are deranged, she's hyperthyroid. Okay, or if you're doing her blood sugars are showing that she's diabetic. Okay, or if she's having any other underlying conditions, medical conditions. Okay, so all these things you need to pick up by doing a routine blood investigation. And if you detect any of these abnormalities, okay, suppose if you've detected that she's anemic and that anemia was the reason why, the pregnancy was going to fail. Okay, so what you do, you're going to correct that anemia. Okay, or if she's having a UTI, okay, you're going to start treating her for the UTI. So you need to find what has caused the threat and then start treating that underlying cause. Okay, you do a transvaginal ultrasound to look for the location of pregnancy. You determine the viability. Okay, this sentence, what it means, what I mean to say by this is, sometimes you can look for a subchorionic bleed. Okay, subchorionic hematoma, bleed. Okay, but these sort of things, if you take a proper care, the pregnancy will continue. and then you will see a gestational sac and you will see a yolk sac. So that means the pregnancy is continuing to be healthy, but there was a threat which you should, cater to and let the pregnancy continue. So what are the advices that you'll give to such a patient? You'll reassure her, saying that, okay, fine, we will do our best to, help you continue with the pregnancy, and the baby is still, to the at this level, at this point, the pregnancy can still be saved. Okay, that's how you reassure her, and you advise her a good rest. Okay, avoid coitus. Okay, avoid lifting heavy objects and avoid traveling. Another thing you need to ask her is to continue taking her folic acid supplements. Okay, and the pregnancy hormone being progesterone. So what you're going to do is you're going to give her either orally, or you can give her per vaginally, or you can give injectable form of progesterone, or even there are progesterone gels, okay, which can be inserted per vaginally. So all these modalities of different forms of progesterone can be given to help with the continuation of pregnancy. Antimicrobials in case of suspected infections. Okay, so that was threatened abortion. The next case is the patient comes with symptoms of excessive vaginal bleeding and excessive abdominal pain. Okay, so now the term excessive and pain and bleeding, so it's something which is alarming. Okay, these are not the normal symptoms of pregnancy. So this is something which is alarming. Okay, so patient comes to you okay. The patient might either have, she would have come immediately to you. So that means her vitals will be stable. But if there has been a delay in her arrival to you, she would have, had signs of shock. Okay. So that's the signs. The general condition depends upon the amount of blood loss. So at this point, you'll do a perspective examination. You will notice that the cervical os is open, okay, and there are clots and products seen protruding through the os. Okay, when you do a pervaginal examination, both the internal and the external os is open of the cervix, okay, and the products of conception are felt. When you do a PV examination, you can feel that the products of conception are in the vagina or in the cervix, okay, in the cervical canal. And the size of the uterus, it feels smaller than the period of amenorrhea. If she is like an 8 weeks of gestation, the size of the uterus feels almost 6 weeks. So what do you think this case is? Um, there are certain answers like missed, complete, again incomplete. Anything else? So the answer to this is an inevitable abortion. Okay, I understand you can get a little confused with incomplete, but let me explain. It might be clearer then. An incomplete abortion is the process of abortion has started, okay, and has reached a point where you cannot do anything to save the pregnancy. See, the hint here is the products of conception were already outside. Okay, most of the time the patient would have expelled everything either in her home before arrival to you, or as soon as she arrives, you would have felt it at the os, and that means there is. And when you do an ultrasound, there's nothing seen on the ultrasound. Okay, that means the entire product has gone off. Okay, so that sort of an abortion is inevitable. You cannot do anything at this point to save the pregnancy. So that means that is the meaning of the word inevitable. Okay, you cannot do anything to stop such a condition. Okay. Okay, the next case is that of a patient with anemia with shock, okay, history of expulsion of a fleshy mass and blood clots and abdominal pain, persists, PV bleeding persists, okay. The highlight here is the bleeding and the abdominal pain is persisting, okay. but she gives history that she expelled something. She saw some amount of bleeding initially, and after that, she's continuing to bleed. Okay, the bleeding doesn't stop, and the pain abdomen also doesn't stop. Okay, and when you do a per-vaginal examination, the uterus feels smaller than the period of amenorrhea. The cervical os, it admits either 1 or 2 fingers, and the products are felt through the os. Okay, um, on on ultrasound, you can see products of conception. Now, what is this condition? Okay, so this is, I'm sorry, I'm not able to see the chat box anymore. Oh, yeah, okay, so yeah. So this, yeah, this is a case of an incomplete abortion. Okay. I will get to the difference between incomplete and inevitable abortion. Okay. So what happens in case of incomplete abortion? The process has started, okay, but it has not been completed. In inevitable abortion, everything has come off, okay. In incomplete, something remains and something has been expelled. That is why in case of an inevitable abortion, the patient will suddenly have severe pain and a huge gush of bleed. Along with that, the products of conception also gets expelled. After that, the bleeding and the pain stops. Why? Because nothing remains inside. Okay. In incomplete, why does the bleeding and the pain persist? It is because some products remain inside. Okay. So it is by nature that the uterus, okay, what it does is if something remains, no, if there is something, some products of conception, if it is remaining behind, it tries to further contract. That is why the pain, and it tries to expel it out. That's when you see the bleed. Okay. So in incomplete abortion, the bleed and the pain persist because some products are still inside the uterine cavity. Some would have been expelled and some remains. So that is why it is called as an incomplete abortion. So here you will see that this is the retained product of conception, which is seen on ultrasound. Okay. Um, so uh, in incomplete abortion, what happens is some products of conception has been expelled, but some gets retained, and this sort of retention leads to continuous bleeding and continuous abdominal pain. Okay, because the body is trying to expel the remaining things outside. So at this point, the patient comes to you, and you will find her already anemic. And when you do an ultrasound, some products are already remaining inside. Okay, so what do you do at this point? Okay, first, what you do is it depends on the patient's condition. If she's somebody who's, bled quite a lot, okay, at home, and she's come to you with severe anemia, and or in case of, or as she's come in state of shock, then you're going to resuscitate her first. Okay, airway, breathing, circulation. You're going to, see to it that you've stabilized the patient, and once the patient has been stabilized, okay, then based on the period of gestation, you would like to further help in evacuation of the remaining products of conception. So either what you do is, if the cervix is just 1 centimeter dilated, you will help to dilate it further. Okay, so dilatation of the cervix followed by evacuation. There's something called as an OM forceps. Okay, an OM forceps is used to remove the remaining products of conception. This is by either you can either sedate the patient and do this procedure, or you can take her to the OT and give her sedation, and you can do this procedure. Okay, so that is dilatation and instrumental evacuation by using a OM forceps. Okay, but if the period of gestation is more than 12 weeks, you can even try medically, okay, by using misoprostol and help in evacuation of the remaining products of conception. At the same time, an oxytocin drip can also be used so that the uterus contracts, okay, and whatever the remaining products are can be expelled out. Okay, now once you've done either medical management or Even for that matter, if you've done a surgical, it is always safe to repeat a check, do a repeat scan before sending the patient off. So to confirm that the whatever you've the products of conception which is remaining, it has all been expelled and there's nothing further remaining inside the uterine cavity. So that is when you would do a check scan. Is there any more confusion between incomplete abortion and inevitable abortion? Okay, so I suppose you've understood the difference between inevitable and incomplete abortion. Okay, that's clear. Then I'll move on to the next one. Okay, so the next case is what happens is the patient presents with complaints of expulsion of fleshy mass followed by subsidence of abdominal pain and bleeding PV. Okay, here also on when you do a per speculum examination, bleeding may or may not be observed. Okay, and uterus, the size is smaller than the period of amenorrhea, and uterus is formed and os is closed. Okay, ultrasound is showing just a normal size uterus or a bulky uterus, and the uterine cavity is empty. So what is this now? So what are we discussing in this? Yes, this is a case of a complete abortion. So the patient arrives to you, okay, with the process of abortion being totally complete. Okay, so why are we calling it as a complete abortion is the cervix is closed at this point because the function of the cervix to have dilated in the beginning and expelling the products of conception, and then nothing remains inside. That's why the cervix closes. That is why it is called as a complete abortion. The entire process for it to complete is it begins with dilatation of the cervix, the products will get expelled, and then it closes. So that is the entire process which has gotten completed. That is why it is called as a complete abortion. Okay, so products of conception has been expelled en masse. Okay, and even the uterus has also closed. There is no further bleed. That means everything is complete. But in inevitable, what happened is the products were there. Okay, you cannot save the pregnancy anymore. What you're going to do is the rest of it has to go out. The rest of the product has to go out. And then you should give some uterotonics to maybe contract the uterus. And you have to give some time for the cervical os to close. So that is inevitable. Incomplete, all this process is done. And then she's coming to you with an empty uterus. That is a complete abortion. Okay. I think a few of you have been commenting on missed abortion, right? So yeah, now the last one is missed abortion. So what is this missed abortion? Okay, let's start with a scenario. 28-year-old gravida to para 1, she comes with a 10 weeks history of amenorrhea, followed by scanty brownish discharge. There is no pain, there's no passage of fleshy mass, there is no PV bleed. Okay, per abdomen wise, the abdomen is soft, there is no tenderness, there's no contraction. Okay, per speculum, the cervical os is closed. Okay, the cervix is closed. When you do a beta HCG value, you're getting a value of 18,500. Okay, it means you think of an intrauterine pregnancy. And then when you're on ultrasound, okay, that's when you see to it that though you can see the fetus, okay, you can measure the crown rump length. Okay, you can see the mean sac diameter, but the gestational sac is not regular. It is getting a little shriveled, okay, or it is getting collapsed, is what you see in the gestational sac. But the cervical os on this thing on ultrasound as well, the os is closed. So this sort of an abortion is called as the missed abortion. Here you can see on color Doppler, there is no cardiac activity. Okay. So this sort of condition is called as missed abortion. Here again, the term explains as to why it is called as a missed abortion. What happens is when somebody when the pregnant patient, she bleeds, she thinks that, okay, fine, I may be aborting, isn't it? But in this case, no, she will not bleed. She will not have any abdominal pain, nothing. So it is missed by the mother or by the patient. The patient misses knowing that, okay, I may be losing my pregnancy. Always bleed is something, or pain is something which, hints as abortion. But here, all these symptoms are not there. It's just that she's come for a routine ultrasound and there's no fetal cardiac activity. So that is why it is called as missed abortion, because the abortion process has been missed by the mother because she's not bled or she's not had any abdominal pain. That is why this sort of condition, where, in this, most of the time it can even be like this. The first scan had shown a good cardiac activity. Subsequent scans, the cardiac activity stopped. Okay, it can even be presented in that way. So this situation, or this scenario, is called as a missed abortion. So the fetus is dead, okay, but it is continuing to be retained inside the uterus for a variable period. So that is a missed abortion. That in the sense, she has not started bleeding or she's not had any abdominal pain for her to realize that the baby is dead. Okay. But what happens in missed abortion is, after, nowadays we have ultrasound, isn't it, to pick up all these things. But had you not done an ultrasound, the body will spontaneously try to expel it out, because the body at this point knows that, okay, this is a dead fetus. So the body itself tries to remove it. Okay. So nature will take care of it. But since there is medical help, okay, what we can do is we can induce the process of abortion in this patient. Okay, because fetus is already dead, there's no point in continuing the pregnancy. So we can give certain medications to help in the process of abortion. So the main modality is misoprostol. Misoprostol is prostaglandin E1. Okay, it helps in the dilatation, effacement, and expulsion of the products. Okay, so either you can do a medical management or you can do a surgical management by dilatation and evacuation. Okay, you dilate the cervix, and then whatever products of conception are there, you remove it off. Okay, because the pregnancy is, the fetus is dead, so there's no point in keeping the dead fetus. So you help in removal of it by doing doing either a medical or a surgical management. So are we clear? Just go through this table, and if you have any doubts, you can ask so that we can proceed to the next topic. Oh, sorry, this table will not be visible, no? Okay. Shall I revise the table?
The table is visible, madam.
Yeah.
It is visible.
Okay, let me just have a quick revision before I move on to the next topic. So the different types of abortion. First is a threatened abortion. Threatened, they may have a mild spotting. Okay. Pain usually is absent or minimal. The cervical os is closed. The products of conception are not expelled. The pregnancy can continue. Okay. So that is a threatened abortion. Inevitable, there'll be a heavy bleed. There'll be a heavy bleed. Pain will also be present. The cervical os is open. The products of conception, they will be in the process of expulsion. Okay, so they would have been in the lower uterine segment or in the cervical canal, and this sort of abortion is inevitable, in the sense you cannot do anything to save this pregnancy. That is inevitable abortion. In incomplete, the patient will have a heavy bleed. Why? Because some products are still continuing to be retained inside the uterus. Okay, and so at the same time, because it's retained, the body is trying to expel it. That is why pain is also seen, and the cervical os is open because, yeah, the process hasn't been completed. Once the process is complete, the os will close. But here, process incomplete, that's why os will continue to remain open. Okay, and the products of conception is just partially expelled. And on ultrasound, you'll see retained products of conception or RPOC. In complete abortion, you have initially the patient will bleed. Initially, the patient will have pain, followed by stoppage of bleed, stoppage of pain. So when she comes to you, the os will remain closed. The cervix is the uterus is completely empty because there is no products of conception. Okay, and everything has been expelled. The entire process is complete. That is a complete abortion. Missed abortion, it is missed by the mother. She doesn't know that the pregnancy is no longer viable, or the fetus is dead inside. She's not aware of it. That is why it is called as missed abortion. So here the patient will see either minimal or no bleeding, okay, or some brownish discharge. Pain is usually absent. The cervix is closed, but on ultrasound, the fetus is dead inside. Okay, so this sort of pregnancy is non-viable. Septic abortion, less seen nowadays because we have medical MTP as a regulated way of carrying abortion. So septic abortion less seen, but for completion sakes, what happens is bleeding can be variable. Pain also will be variable. Os, it may or may not be open. Products of conception may be present. Mostly, this sort of a miscarriage will be accompanied by infection. Okay, so that is a septic abortion. Okay, so with that, we complete abortion. Okay, the first complication which can be encountered in the first trimester. Moving on to the next one. Okay, here is a case of a 28-year-old. She comes to the casualty with a 7 weeks history of amenorrhea and sudden severe lower abdominal pain. She also has giddiness, fainting episode, vaginal spotting since morning. Okay, her vitals, you can see that she's having tachycardia, she's hypotensive, she appears pale, restless. Per vaginal examination shows cervical motion tenderness, can feel a fullness in the right fornix. Okay, urine pregnancy test is come as positive. So what you need to remember is, whenever, whichever department you're in, okay, make sure you always ask, if it's a female patient, ask her last menstrual period. Okay, always pregnancy has to be suspected if she's giving a history of amenorrhea. Okay, because if you don't suspect pregnancy, it's a major negligence that you're going to be doing from your end. Okay, so that is why always, first thing, in whichever department you are, if it's a female patient, ask when is her LMP. You will get the period of amenorrhea. Once you get a period of amenorrhea, see to it that you do a urine pregnancy test. Okay, so yeah, in this patient, the urine pregnancy test came positive. So once it came positive, since she's bleeding, we would like to know what is happening to the underlying pregnancy. So the beta HCG came as 3,900. Okay. When an abdominal examination was done, there was diffuse tenderness, there was guarding rigidity was present. Okay, transvaginal ultrasound showed an empty uterine cavity, but a mass in the right adnexa, and there was free fluid, okay, a hemoperitoneum seen. So what do you think this condition is? Yes. So the correct answer is a ruptured tubal ectopic pregnancy. Okay. So this is a case of a ruptured tubal ectopic pregnancy. So what is an ectopic pregnancy? A pregnancy where implantation is taking place anywhere other than the uterine cavity. So that is an ectopic pregnancy. It can even be addressed as pregnancy of unknown location. If you know that the urine pregnancy test is coming positive, but you're not able to find where the pregnancy is, it can even be termed as a pregnancy of unknown location. There are many different locations where pregnancy can even implant. The most common site is a tubal ectopic. There are other sites, like an ovarian pregnancy can take place, an abdominal pregnancy can take place, a cervical pregnancy can take place. Okay, these are all very rare cases. Okay, there's something called heterotropic pregnancy, where you can have an intrauterine pregnancy as well as an extrauterine pregnancy or an ectopic pregnancy. Okay, so all this comes under pregnancy of unknown location or ectopic pregnancy. So here, this was a case of a ruptured tubal ectopic pregnancy. The fluid seen was the hemoperitoneum, the empty uterine cavity, because nothing inside because it's not an intrauterine pregnancy, and the right fornix was full because it was a right tubal ectopic. Okay, it was near the right adnexa, that means the right tube. And the hemodynamic instability says that the patient is having that the patient is having bleed somewhere, and in this case she is bleeding inside her abdominal cavity. Yes, yeah, she is in a state of shock. Okay, so what are the various ultrasound findings that ectopic pregnancy is something which you have to always suspect. You should have a high degree of suspicion to call it as an ectopic pregnancy. Okay, patient will have abdominal pain, less likely for them to have an external bleed. Okay, they may not have, some cases you may see a slight bleed. Okay, that is just a decidual cast which may be shedding, but most of the time it's either abdominal pain that they come with. Okay, so any pregnancy with abdominal pain and no bleeding per vaginally do have a suspicion of ectopic pregnancy. So ectopic pregnancy, once you suspect, the main modality of finding it is on the radiologist. They have to locate where this pregnancy has been implanted and give you that information so that you can go ahead with the management of it. So what are the findings that you'll see on ultrasound? You'll see a pseudo sac, which is a fluid. You know what? I'll just directly go to the ultrasound images. Okay, so this is a pseudo sac. This is the uterine. This is the uterus. Okay. See, this is a uterus. This is the uterine cavity, but there has been a sac-like thing. Okay, you remember the sac that we saw previously? It was like a round eccentric sac. Okay, a regular round eccentric sac, but this is like in this form. Okay, so this is a pseudo sac, in the sense the uterus knows that there is beta HCG and there is some pregnancy. The uterus feels like it should prepare itself, so that is why it's forming this sort of a sac-like thing, but it is empty. Okay, so this is just a fluid collection between the endometrial layers to it takes the shape of the uterine cavity. Okay, so that is a pseudo sac. Okay, next, what you see, another finding is a decidual cyst. Okay, these are anechoic cystic areas within the endometrium. Okay, remote from the canal. So this is the canal. Okay, it is away from the canal, which it is seen, and often at the endomyometrial junction. So this is also another way of uterus thinking that, okay, maybe the pregnancy will come to inside it. Okay, but it's how can I say, it's just uterus way of preparing itself for pregnancy. Though the pregnancy is not going to get implanted inside it, but it thinks that it should prepare itself. That is why these changes are seen inside the uterine cavity. Okay. Next is, so that is the status of the uterus. So an empty uterus is the first sign. Next sign is that of an ectopic mass. Okay, so once you give the history to the radiologist or yourself, if you're doing the scan and UPT is positive, then you're in search for the just 1 minute. Okay, sorry about that. So next thing, when you know that the uterus is empty, you will be in search for where else is the pregnancy, because the pregnancy test has come positive. Pregnancy has to be somewhere. So Next most commonly looked at site is the adnexa. Adnexa is the tubes and the ovaries, right? So when you see an adnexal mass separate from the ovary, okay, you see the ovary separately and you see the mass here, okay? So this is the ectopic mass, this is the right ovary. So when you see an adnexal mass separate from the ovary, that is when you suspect it to be an ectopic mass. There's something called a tubal ring sign. Okay, here a hyperechoic halo or tubal ring surrounded by an anechoic sac can be seen inside the tube. Okay, so the sac will be forming inside the tube. So that so the tube is also seen and the sac is also seen. So that is a tubal ring sign. Okay, and then when you put color Doppler around it, you can see that there is flow, there's blood flow. Okay, so this is called, there's a ring of fire. That means there's a ring of vessel blood supply seen to the ectopic pregnancy. So wherever the pregnancy is getting implanted, there'll be a lot of blood flow to that particular area. If it is the uterus, a lot of blood flow goes to the uterus. Now, since it's in the tube, a lot of blood will be flowing to the tubes. So that is why on color Doppler, you'll be able to see this ring of fire appearance. So these are the typical ultrasound features that you'll see on in a case of an ectopic pregnancy. Sometimes in this, you can even see the if in case it's gone to a little more advanced stage, you can even see a fetus with the cardiac activity. Okay, so now how will you manage this case? So your main management will be based on how the patient has presented to you with her hemodynamic stability. Okay, if she is not hemodynamically stable, first thing what you do is you do the basic resuscitation. Okay, again, airway, breathing, circulation, you secure all of that. You start large IV bore cannulas. You give hydration. You make sure that she's not going in for shock. Okay, the fluid resuscitation part you take care of. Okay, and then you stabilize her, you give her oxygen. Okay, so that because she's lost so much blood already, all the organs should not go in for a shutdown. Okay, so you start off oxygen for her. Okay, and then immediately you do an ultrasound, and when you pick up this thing, a ruptured ectopic, you shift it to OT. Okay, that is in case of a patient who's not hemodynamically stable. Okay, but if the patient is hemodynamically stable, then what you do is you can you can think of a medical management. Okay, so yes, you would like to know what is the baseline beta HCG levels. Okay, in case of a ruptured ectopic, it does not make any difference. Okay, the beta HCG level, but in case of when you're thinking of medical management, the beta HCG level is of importance. Okay, the baseline level. Then the size of ectopic is also important when you want to know about your modality of management and the women's choice. Okay, so based on all these features into consideration, you'll know how to manage your case. So you have either medical management with methotrexate and surgical management. Surgical management, what you do is you do a laparotomy. That means you either open surgically, like the abdominal walls, or you use your laparoscope and you will try to either do a salpingostomy. Salpingostomy is just opening that tube and evacuating the product of conception. Okay, salpingectomy is you completely remove off the entire tube. Okay, so that is salpingectomy. Okay, you remove off that entire ruptured tube. That if it's a ruptured tube, it's you cannot save the tube anymore. It's ruptured, it's damaged completely. There's no saving the tube. But if the tube is not ruptured, you can just make a nick on the tube. That means an ostomy, an opening on the tube, and evacuate whatever has been inside that tube and let that tube heal on its own. So this is a way, this is that woman's choice. Okay, so if she wants the tube to be saved, okay, you can either do a procedure like a salpingostomy. If not, the tubes have ruptured, there's no you cannot salvage the tubes. That means you have to go ahead with salpingectomy. So this is surgical management. In medical management, the main drug of choice is methotrexate. Methotrexate is an antimitotic agent and it acts on viable trophoblastic cells. The lab parameters to be done before starting the patient with methotrexate is you need to have the patient's hemoglobin level should be normal, her total count should be normal, the liver and the renal function test should be normal before starting methotrexate. Okay, and after starting methotrexate, the patient should be counseled regarding the possibility of long resolution period. It's not just you give one shot methotrexate and it's done. It's not. It doesn't stop at that. Okay, you will need to continuously monitor the patient. Her hospital stay might get prolonged. Okay, and there's an increased waiting time for future fertility if desired. In sense, you cannot she cannot get pregnant soon. Okay, she will have to wait for the beta HCG to completely settle before she plans the next pregnancy. Okay, and you have to even explain the possible side effects of methotrexate before starting and the possibility of emergency surgical intervention and unscheduled hospitalization. In the sense, once you've given methotrexate, you cannot be 100% sure that it'll work. Okay, there may be times when you might have to even if you start methotrexate, it may fail and you may have to do a surgical intervention. So you have to explain all of these things before starting methotrexate. So basically, methotrexate is something where you're trying to salvage the tubes, at the same time not subjecting the patient to surgery. Okay, that is the role of methotrexate. So how do you choose the patient for offering her methotrexate or the medical management? So once you've diagnosed tubal ectopic, if the patient is not able to return for follow-up, in the sense the patient is hemodynamically unstable, she has significant pain, the adnexal mass is larger than 3.5 centimeter, there's a visible cardiac activity, and the beta HCG more than 5,000. Okay, so these sort of patients, you will not offer medical management. But if the patient is hemodynamically stable, there's no significant pain, the tube has not ruptured, and the size of this ectopic is less than 3.5 centimeter, and no fetal cardiac activity is present. So that's when you assess by doing a beta HCG level. Okay, if beta HCG is between 1,500 to 5,000, so less than 5,000, that means you offer her the medical choice of management. Okay, if the beta, in the sense, at this point you can give her both the options. Okay, but if it's definitely less than 1,500, then methotrexate should be the first line of management. So in this case, between 1,500 to 5,000, the chances of medical management failing will be more. Okay, so that is when you can give her the choice as to what she wants, and based on her choice of treatment, you will go ahead. Okay. So now how do you give this methotrexate? You have either a single dose regime, a 2-dose regime, and a multi-dose regime. Okay, single dose regime is most commonly given. Okay, the dosage of methotrexate is 50 milligram per meter square. It is given intramuscularly. And then once you give that, you will monitor the beta HCG level on day 4 and day 7 after giving the therapy. Okay, so first you do a baseline beta HCG and then you do at day 4 and day 7. So when you know it's a successful, your treatment is getting successful, is the beta HCG will fall more than 15% between day 4 and day 7. Okay, that means she's responding to the therapy. That means a fall in beta HCG, okay, of more than 15% should be seen. Then after the level is falling, the further follow-up you have to do by a weekly serum beta HCG values till the level becomes undetectable. Okay, but in case this beta HCG level is not falling less than 15%, what you can do is you can give a repeat dose of methotrexate. Okay, a maximum of three doses can be given. So when do you know when to stop? If suddenly the patient becomes hemodynamically unstable, that means suddenly this pregnancy has the tubes have ruptured, the patient has got increased pain, okay, and you're suspecting rupture, that means you cannot continue with your medical therapy. Okay. So most important is your pre-treatment beta-HCG level. If the level is less than 1500, the success rate is higher, 98%. But if the beta-HCG level is between 1500 to 5000, success level reduces. Okay. And another advice you need to give post-treatment is to avoid pregnancy for the next 3 to 6 months. Okay, because if she gets pregnant and the beta-HCG is still, on the detectable side, so we'll not be able to distinguish. Okay. And then advise preconception folic acid before the next pregnancy, because why? Methotrexate is a folate antagonist. So it is necessary that this folate, this methotrexate levels have, completely gone off from her body, so that she can, she does not have the ill effects of methotrexate in the next pregnancy. Okay, so that is another reason why pregnancy has to be avoided for the next 3 to 6 months. So you either have a, just 1 minute. So you either have a single dose or a multi-dose regime. Single dose, what we just discussed. Okay, you give a single dose, then you repeat beta-HCG on day 4 and 7. Okay, and if the levels are reducing less than 15%, between day 4 to day 7, that means your therapy is working. In case it is not declining, that means you can again give a rescue dose of maximum of 3, and then you do a post therapy surveillance weekly till the beta-HCG becomes undetectable. In a multi regime, what you do is you have methotrexate. Okay, you can give 4 doses of the drug, and there's another one called as leucovorin. Okay, these are folinic acid supplements. Okay, you give methotrexate on day 1, day 3, day 5, and day 7. Okay, and alternate days you give leucovorin. Okay, this is given on day 2, 4, 6, and 8. And beta-HCG levels are to be done on day 1, day 3, the day that you're giving methotrexate, same days you're going to check for the beta-HCG levels. If serum beta-HCG declines to less than 15%, give the additional doses. Repeat serum beta-HCG in 48 hours and compare with the previous value. Maximum of 4 doses are to be given. Here, just the addition of leucovorin, so to avoid the side effects of methotrexate. Okay, and then here you do weekly beta-HCG to till it becomes undetectable. The side effects of methotrexate, it has liver toxicity, stomatitis, gastroenteritis. Okay, so these are the side. So that's why you have to monitor the LFT of the patient. Okay, CBC as well. Look for the drop in. It can cause bone marrow suppression as well. Okay, so you have to look for the total count as well. Okay, and then there's something called separation pain. In this, what happens is you're going to try to remove that implanted pregnancy from the tube, right? Sometimes when that is getting separated, the patient can have mild pain, and very rarely, maybe like 10 to 15% of the time, they can have severe pain. Okay, that is separation pain. That is when you may get confused that maybe she has ruptured. Okay, so that is something called as a separation pain seen in methotrexate. Another thing is this sort of medical treatment, it can either it can either have a failure, because of which you may have to subject the patient to a surgical management. Okay, so are we clear with ectopic pregnancy? Is the topic ectopic pregnancy clear? So let's move to the last topic. That is, okay, this is the scenario. A 24-year-old presents to you with 10 weeks of amenorrhea, excessive vomiting, okay, since 1 week, vaginal bleeding, spotting, progressing to bleed, and lower abdominal discomfort, and no fever, okay. On examination, her vitals are stable. The pulse is 110 beats per minute. BP is stable. Okay, there is no fall. She's not having hypotension. Okay, the patient looks slightly pale, anxious, appears dehydrated, and you can see that she's actively vomiting. Okay, the uterine size is enlarged more than the period of gestation. Though she's just 10 weeks as per her LMP, the uterine size is corresponding to 16 weeks. Okay, so the period of the uterine size is also more than the period of gestation. Okay, but it is soft, it is non-tender, no guarding, no rigidity on abdominal examination. On per vaginal examination, the cervical os is closed, the uterus is bulkier more than the period of gestation, and there's no adnexal mass or cervical motion tenderness. Okay. On investigation, urine pregnancy test is positive. Since she's had 10 weeks of amenorrhea, we'll subject her to UPT. UPT is come positive, and you've done a serum beta HCG level. It is markedly elevated of 2,45,000. Okay, this high level of beta HCG is something which is not seen at 10 weeks of gestation. Okay, it'll probably be in thousands, but not in lakhs. Okay, but this beta HCG level in lakhs is something which is alarming, and that is when okay, along with that, you do a hemoglobin level. Hemoglobin is stable. Okay, it's 9.2. Okay, that means she is not having some underlying bleed. Okay, TSH is suppressed. Okay, LFT, RFT are within normal limits. Ultrasound showing a snowstorm appearance of multiple cystic areas within the enlarged placenta. No fetus is seen, and sometimes the ovaries, it may have bilateral theca cysts. Okay, and these are the flesh, the grape-like vesicles, which the patient gives the history of, expelling. So what is this condition? This is a case of a molar pregnancy, okay, or hydratiform mole. So yes, we are dealing with the case of a hydratiform mole or a molar pregnancy. Okay, molar pregnancy is a unique first trimester complication characterized by abnormal trophoblastic proliferation and excessive beta HCG production. Okay, beta HCG production. Okay, so this is a case of a hydratiform mole or a non-molar trophoblastic malignant neoplasm. So if in case there is a molar pregnancy, it can be a molar lesion or a non-molar lesion. Okay. That means it can be either benign or malignant. That's what this is trying to explain. Hydratiform mole can be either complete or partial mole, or it can be invasive. It can invade through the myometrium of the uterus. So that is a invasive type of mole, or it can turn malignant. Okay, that is a non-molar lesion. The non-molar lesion, the malignant part of it is choriocarcinoma, or a placental site trophoblastic tumor, or an epithelioid trophoblastic tumor. So these are all benign conditions. These are malignant to semi-malignant lesions. That is the non-molar lesions. We'll be mainly dealing with the hydratiform mole, the pregnancy-related non-malignant condition. Okay. So what leads to this molar pregnancy? Here, what happens is there's an abnormal fertilization. Okay. Once there's an abnormal fertilization, it leads to an abnormal placentation. Because of this abnormal placentation, there can be excessive production of beta HCG. Okay. So what happens is there are two major types of moles. One is complete mole or a partial mole. The word complete mole is, it says it is called as complete mole because it is full of that vesicles. Okay. Partial is, it is partially vesicle, partially the fetus. That is why it's called as partial mole. Okay. Half of it is mole and half of it is the fetus, like this image. Okay. This is a partial mole. This, where it's completely filled with that vesicle, it is called as a complete mole. Okay, so what happens in a complete mole? Here, the karyotyping is 46XX or XY. Okay, a diploid a number of chromosome. Okay, so what happens? The ovum is empty. Okay, and this gets fertilized by one sperm which duplicates. Okay, so this sort of mole, it's completely paternal in origin. So there's no maternal chromosome. In the absence of maternal chromosome, just the paternal chromosome duplicates, and that leads to formation of 46XX or XY. Okay. In case of a partial mole, it is triploid in number. How does this become triploid? It is because a normal ovum, the ovum will have the chromosomal material. It is fertilized by the two sperms, okay, or by one diploid sperm. Okay, so that is why um, uh, the chromosome material in this will be triploid 69 triple X or X double XY or X double Y. Okay, so one set of maternal and two set of paternal chromosomes will be present in that. So this is the difference between complete and a partial mole. Okay, the genetic imbalance that starts here. This reflects into the placentation. So in complete mole, what happens is there's diffuse trophoblastic proliferation seen by marked hydropic swelling of the chorionic villi. So these are basically the chorionic villi, which will be markedly edematous. Okay, so that is why it looks like this grape-like vesicles. And since it's complete, there is no fetal parts. Okay, in partial mole, what happens is half of it is the fetus. Okay, the rest half is the trophoblastic tissue. Here there is focal villus edema. A focal area will have the villus edema. The trophoblastic hyperplasia will be seen, and the fetus may be present. So because of all of this, because of a lot of chorionic villi, okay, the beta HCG will be highly elevated. Okay, so the hyperplastic trophoblastic trophoblast, they produce a large amount of beta HCG. That is why you're going to see the beta HCG in lakhs, okay, which is not seen in earlier gestations. So as a result of this, what happens is either this sort of a pregnancy will spontaneously get aborted, mole may be expelled spontaneously. Sometimes this mole can invade through the myometrium. Okay, that is the persistent trophoblastic tissue or an invasive mole. Sometimes this sort of marked duplication. See, malignancy is always rapid multiplication, isn't it? So here also rapid multiplication, if it starts, then it's going to lead to malignant transformation or choriocarcinoma. So what happens as a result of this? Because of excessive beta HCG, they can have hyperemesis or excessive vomiting. The uterine size is more than the period of gestation because it is full of those rapidly dividing grape-like vesicles. Okay. Vaginal bleed can also be seen because these tissues are very friable and it can, try to get aborted. So that is when profuse bleeding can be seen. Theca lutein cysts. These are cysts seen due to overstimulation of the ovaries. Now there's a lot of beta HCG, okay, and so what the body feels like, there's a lot of there's sudden increase in LH is what the body understands, and because of that there'll be a rapid stimulation of the ovaries, and because of theca lutein cysts will be seen in on the ovaries. Okay, since beta HCG also mimics the TSH, it has a similar composition. The beta HCG alpha unit mimics the TSH. Okay, because of this cross reactivity, the patient can have elevated thyroid levels. Okay, that means the TSH will be low. Okay, and T3 T4 will be elevated. So thyroid, a preeclampsia, angiogenic factors, and earlier preeclampsia can also be seen in this patient. So let's just revise again. What is complete mole and a partial mole? Complete mole, it is a diploid, it has diploid chromosome because it's an absent ovum which is getting fertilized by a single sperm which duplicates. Here in partial, this is completely androgenic in origin. This is diandric because the ovum is normal. There is the chromosome material seen in the ovum and it's fertilized by two sperms. So it is diandric in origin. This is done. In this, you'll see grape-like vesicles with no fetus. In this, you'll see partially there'll be grape-like vesicles, but the fetus will be present. Here, trophoblastic proliferation is marked. Okay, here it is just focal trophoblastic proliferation. Fetal parts are absent. Beta HCG levels will be elevated in lags. Here, beta HCG will be also elevated, but not to the extent seen in complete mole. Okay, very highly elevated beta HCG seen in complete. Elevated but not very high is seen in partial. Uterine size larger than period of gestation. Uterine size may be slightly large or corresponding to the period of gestation. On ultrasound, you'll see the snowstorm appearance because of those edematous villi. In case of partial mole, we can see that the fetal part can also be seen along with the focal proliferation of the villi. When you compare the prognosis or the chances of this molar pregnancy transforming to a malignant choriocarcinoma, there's a higher risk in case of complete mole, okay, because it's full of these vesicles, no. But in case of partial mole, the risk is slightly less, 1 to 5%. In case of complete mole, it is 15 to 20% that can turn into a malignant choriocarcinoma. So how do you manage this case? Okay, once you've diagnosed with molar pregnancy, you get a hemoglobin, you get a complete blood count, okay, serum beta HCG levels, okay, creatinine levels, electrolyte levels, liver enzyme levels, okay, thyroid and free T4 levels, blood grouping, RH typing, cross matching, and a chest X-ray. Chest X-ray because sometimes these you can even see the choriocarcinomas. It can even metastasize to the lungs and they can be metastasis to the brain as well. Okay, so to rule out metastasis is when you would like to do a chest X-ray. But the mainstay of treatment is by doing a dilatation and suction evacuation. So you're going to dilate the cervix and you're going to suction out all these grape-like vesicles. Okay, so this is how you do us. You dilate the cervix first. After dilatation of the cervix with the Heggar's dilator, you're going to insert a Carman's cannula. Okay, a Carman's cannula will be attached. It'll be a plastic suction which is attached to the suction machine, and then you're going to apply the suction. It's going to suction out whatever the products are there, which it will be removed inside the cannula. Okay, until all the products get suctioned out, and then the uterus collapses. Okay, you can even check the size of the uterus. It will be reducing. You can also make use of operative ultrasound machine. Okay, ultrasound guided suction evacuation can also be done. In such situations, avoid curating because you can easily end up perforating. Okay, that is why avoid curating. Okay, so while evacuating, the patient can have a massive bleed, okay? Because if it's invasive type of mole, then she can have torrential bleed. Okay, so a large IV bore access to be secured, blood bank to be ready with the blood and blood products. Okay, once you mechanically dilate, you're going to insert a suction catheter called as the Carman's cannula. Okay, and depending on the size of the uterus, the cannula is selected. An oxytocin infusion can also be used so that the uterus remains in the contracted state and you don't have a profuse bleed. And as I explained, an intraoperative, you can use an ultrasound guiding so that you know that the entire process of evacuation is complete. Because there'll be so much of vesicles that you will not know when to stop and how much to suction out. Okay, and you don't want anything to get retained inside. That is when an ultrasound may be helpful. Post evacuation, if she's RH negative, you give an anti-D. Okay, close monitoring of the serum beta HCG level is very important. Monitoring of beta HCG level in case of molar pregnancy is highly recommended. So the first baseline, once the patient comes, you get the baseline, isn't it? After that, after 48 hours, you repeat the beta HCG level. Okay, and then you're going to keep repeating every week for 3 consecutive weeks till the level becomes undetectable. Okay, so what is the time taken for resolution of this molar pregnancy? 7 weeks in case of a partial mole, and a little longer, that is 9 weeks in case of a complete mole. So after this beta C levels become undetectable, it is confirmed monthly for another 6 months. So this takes much more time compared to ectopic. Okay, because the beta HCG level was very high, it was in lakhs, isn't it? So that is why it takes more time for the beta HCG to become undetectable. So at this point, since it's taking months, okay, you have to advise contraception. Because if she gets pregnant, again, there's a confusion if that previous mole has been resolved or not. So the most common recommended contraception is either combined OC pills or injectable progesterone, like DMP or progestin implant. So your mainstay of treatment is evacuate all the molar tissue, you prevent all the complication, okay, and then you monitor the beta HCG to detect any persistent gestational trophoblastic neoplasia. Indication for evacuation, confirmed complete or partial mole, symptomatic, larger uterine size, very, actually there's nothing like indication for evacuation. You have to evacuate. Okay, the moles have to be evacuated. Okay, there is no medical management in case of molar pregnancy. Okay, preferred method is suction evacuation. Okay, the pre-evacuation we've already discussed. This is a process of evacuation. Now, the post-procedure care is of utmost importance in case of a molar pregnancy, because here you're in the lookout for choriocarcinoma or persistent trophoblastic neoplasia or the GTN. Okay, the neoplasia is what you're worried about. So that's why post-procedure follow-up is very important. Okay, what you're going to do is you're going to monitor by doing the beta HCG level. So you've got a baseline done. So after 48 hours, you're going to repeat the next, after 48 hours of evacuation, you're going to repeat the beta HCG. Then you're going to do weekly for 3 consecutive weeks till it becomes negative. After it becomes negative, you don't stop at that. Like how you stopped in ectopic, you don't stop here. Okay, you continue monitoring. Okay, monthly for the next 6 months. Okay, and then yeah, so basically you have to monitor the patient till it, even at least for 6 months. Okay, and this 6 months duration, you have to ensure that the patient takes adequate contraception. Okay, then when do you suspect that this may be going in for choriocarcinoma or persistent trophoblastic neoplasia? If you feel that there's a plateau in the beta HCG over the next 3 weeks, okay, plus or minus 10% of plateau levels are seen, okay, or if there is a rise in between 2 consecutive weeks, you're seeing a rise, okay, and the beta HCG, it becomes detectable after 6 months of after evacuation, okay, and then when your histology also picks up features of choriocarcinoma, or you're going to look for metastasis to the vagina, next is the lungs, and last is the stage 4 mets to the brain. Okay, when if metastasis also occurs, you can give in case of this thing GTN, the malignancy, you can give chemotherapy. Okay, that is a GTN is completely different topic which I've not gone into. Okay, but what you need to know is even if there is GTN, you can continue. There is option of um, chemotherapy. Okay. Um, so yeah. So the key to molar pregnancy is first you have to diagnose. Nowadays, molar pregnancies are picked up earlier because we have ultrasound. Okay, routinely for all pregnant patients, antenatally, first trimester, we do ultrasound. So it can be picked up early. Most of the places, previously or in rural areas, molars were picked up very late. Okay. And then you have your surgical management is the modality of management. Okay, that is suction evacuation. And then follow-up is of utmost importance because you need to prevent the patient from developing mortality and morbidity from gestational trophoblastic neoplasia. So that concludes all the complications in early pregnancy or the first trimester complications. Any doubts or any topics that you would like to discuss on?
Doctor, I think you missed out. Like initially, the chat was not visible. So there were a couple of questions from the participants. The first question was from
Yeah,
Dr. Sam. Uh,
is it adequate?
sure. Yes, asked, is biochemical pregnancy common?
It's not very common. You may encounter maybe 5 to 10% of cases. Okay, but it's not very common. But yeah, it's something which can be even missed. The patient might not have even been aware. Okay, sometimes patients they wait, no, let me complete 2 months or let me complete 45 to 50 days to do the UPT tests. If patients let that wait, you can miss on biochemical pregnancy because they resume their cycles immediately, no? So that is when it can be even either missed. But sometimes when the patient is very anxious to conceive, the minute they miss their period, they do their tests. In such cases, you can come across biochemical pregnancy.
And there was one more from Dr. Vishwajyoti Ray. Said, did HR can be visible in inevitable abortion in USG? If you want, I
Uh,
can. This is a question. I'll just copy paste so that you can see it.
yeah, yeah. Can heart rate, the fetal
Ah,
cardiac activity is what the question is, I suppose.
yeah, exactly.
Will an
Exactly.
inevitable abortion? No, because it's all um it's all come down to the cervical canal. Okay, so at that location or in the lower uterine segment, it's less likely. The entire thing is shriveled and in the process of expulsion. So less likely for you to see the cardiac activity. It's these are all one thing what you need to understand is abortions are mainly a diagnosis by your clinical examination. Okay, you see the status of the size of the uterus, you see the you make sure that you get the history correctly, and then your per abdomen and PV examination will give you the answer. Okay, you don't really have to do an ultrasound to diagnose the different types of abortion.
There's one more question, madam.
Uh,
I think. When, uh, kindly explain about any. I'm really bad at
One second,
embryonic pregnancy.
embryonic, yeah.
Ah,
The pregnant, not. Uh, as D&D is a blind procedure, how will we know that after D&D evacuation has done clearly? Okay, yeah, this is a good question. Dilatation and evacuation, what you do is you're going to dilate and then you're going to use an ohm forceps to remove the products of conception. Okay, so what you can do to confirm that the products have been completely expelled is you can do a gentle curating. Okay, by doing a gentle curating, you can curate all the four walls of the uterus to check to see to it that the uterus is empty. Another thing, what there are other um, signs which can tell you that the process is complete is you can see bubbling. Okay, when you see bubbling, it suggests that the uterine cavity is empty. Another thing, when you're doing the gentle curating, no, don't do vigorous curating because it's a pregnant uterus. Okay, it can perforate. Okay, or you can cause a damage to the tissues of the uterus. So don't do vigorous curating, just a gentle curating, and you can feel the grating sensation of the empty uterine cavity. That's another thing that you'll be seeing. And once the bleeding stops and frothing is seen, okay, that is another sign. And sometimes once the uterus is empty, no, you can feel that instrument that you're passing, the uterus or the cervix be gripping to your instrument. So that is another sign to know that the D&D process is complete. So I know it seems like a blind procedure, but these are certain, and you are not going to get any more products of conception. Okay, it will completely stop. So that's when you are sure that the process is complete. Routinely, you will not have that sort of a luxury to do an ultrasounded guided D&D in all the setup. Okay, and it's not even needed because these sort of things can be easily um, you know, um, ensured clinically. Okay, but suction evacuation, I am talking about it as ultrasound guide because there'll be a lot of products. The whole uterus will be so enlarged, and you would not want anything to be missed. And these are all very friable type of tissues, no? So there are chances that it can be missed. And if it's missed, no, the patient again after some time will come with a huge bout of bleed, and those trophoblastic cells which will remain will further replicate. Okay, so that is why you have to ensure in case of um, molar pregnancy that you're going to do the dilatation and suction evacuation under ultrasound guidance. Anembryonic pregnancy is it's kind of similar to a missed abortion, but here what happens is the fetus will not be formed at all. Okay, just the gestational sac will be there. Okay, and once a sac has formed, the fetus will not form at all. So the sac will maybe increase to from maybe 9 mm, 18 mm, 25 mm. After that 25 mm, no, there'll be no fetus being formed at all. Okay, you can wait till then. After that, after it's grown to its maximum size, still waiting for the baby to come, it will just shrivel and go away. Okay, so that is an anembryonic pregnancy in which the fetus will not form at all. So it is also a type of missed abortion. In the other type of missed abortion is cardiac activity will be present and then it will go off. So that is missed abortion. You want me to go through the slides once again? Should I just flip through the slide once? Is that what Vajiha is trying to get at? So, Is there any particular slide that you want me to show you, or any particular topic that you want me to just revise? Okay. Any other doubts? Methotrexate is anti-mitotic. Okay. Mitosis takes place. Mitosis is basically cell replication, isn't it? So we don't want that pregnancy to further continue, isn't it? Pregnancy, what happens day by day, there is like rapid mitosis, and the pregnancy will advance to the next stages, isn't it? That's what is happening in the 9 months of gestation. So we want to arrest that multiplication. That is why we give methotrexate, because it is anti-mitotic. Okay. Hope that answers Ashwini's question. Um, what if patient is not willing for pregnancy and early pregnant? The question is not clear. Are you talking about MTP? If you're referring to MTP, Khairunisa, it is the patient has the wish to discontinue pregnancy. Okay. And that is regulated by Government of India under the guidance of medical termination of pregnancy. Okay. In medical termination of pregnancy, there are certain criterias where, the patient selection is done, and the pregnancy can be discontinued as in the interest of the patient. If the pregnancy is because of, failed contraception, or if it is out of um, rape, okay, or a pregnancy in which it is going to, damage the mother's life. So in such cases, the Government of India has laid out certain regulatory guidelines for us under the Medical Termination of Pregnancy Act. So that is if the patient is not willing to continue the pregnancy. What is anti-prega, Ashwini? Okay, I'll just go through the slides as requested by Vajiha. Ma'am, please explain when abortion is at 22 weeks, what is mentioned in GPLA? Okay. At 22 weeks, okay, now we have this, as I explained to you. Actually, MTP is an entirely different topic, which I didn't go to cover in this. In MTP, what happens is there are certain regulation, okay? That is, at 20 weeks of gestation, all the MTPs can be done, okay? From 20 to 24 weeks, okay, that is when you're detecting any late type of fetal anomalies, which is incompatible with life. Such MTPs can be done only if it is approved by a medical board, okay? Once they've approved to it, only then you can carry out the process of MTP. So there's first trimester MTP, which is done by a single registered medical practitioner. If it crosses first trimester, you have to have at least two medical practitioners who have to, agree to who has to agree to carry out the process of MTP. After that, it is a medical board which decides if the pregnancy is advanced to that gestational age. Something on Maladi and Malayan. Maladi, Malayan, these are all contraceptive pills. Uh, um, uh, Mala N is provided free of cost. These are combined oral contraceptive pills. Okay. I don't know how it's relevant to this topic, but yeah, these are all combined OCPs, which contains ethinyl estradiol and levonorgestrel. Any other doubt pertaining to the topic for today? There's another doubt. In primary care may not be available beta HCG. What should be done in that case? You mean to say in a primary health center? Okay, if you don't have the facility of doing beta HCG, then if you're suspecting ectopic or if you're suspecting molar pregnancy, you have to refer to a tertiary care. Okay, because this sort of cases, ectopic and molar, cannot be managed in case of PHC. It has to be referred to a higher center. Beta HCG report, it is based on weekly. When you get a beta HCG interpretation, right, a report, you will have a weekly, how the in week wise what should be the beta HCG values. Okay, you don't really have to by heart those values. What you need to understand is a doubling time. Okay, doubling time in case of a normal intrauterine pregnancy, it will double more than 66% in a time duration of 48 hours. But in that 48 hours, if the beta HCG is not doubling, then you can suspect ectopic pregnancy. If the beta HCG is falling, okay, it was initially maybe 2000, then it fell to 1600, 1400, it's falling, then you can suspect as a failing pregnancy. And then in case of molar pregnancy, the beta HCG will be highly elevated, more than what it has to be, the cutoff level at that particular week of gestation. Compared to that, it will be highly elevated. That is when you suspect um, molar pregnancy. So don't have to really remember at what week of gestation, what is the beta HCG value. This is the thing that you need to keep in your mind. Any other doubts? Shall we conclude the class then?
Thank you, doctor. Thank you for this wonderful session.
Thank you.
Thank you. So participants, please, I've sent you the feedback form. Once you fill the feedback form, automatically the certificate will be sent to your mail ID. Thank you.
Thank you, everyone.